We are so lucky to have Tarryn from the Ovarian Club with us today. And she is a medical expert, our second medical expert of the week. And we are going to be chatting to her about all medical things to do with our ovaries, our female systems, our reproductive system, our health. And I'm going to hand over to you now to introduce yourself to us.
Well, thanks so much, Kat, for having me on this platform. So I'm Dr. Tarryn Kawalsky. I'm actually practicing as a GP. I don't specialize in women's health per se, but it is most certainly a special interest of mine after having completed my community service year 2 years ago in obstetrics and gynaecology. So I believe I know a thing or two when it comes to the female reproductive system. So yes, I am currently based as a GP at the University of the Western Cape, where I consult many patients, predominantly females, which is obviously very exciting for me. And I've since co-founded the Ovarian Club, which is a podcast between my friend Emma and I. And basically we just share conversations, casual amongst friends. One happens to be a doctor, the other one's a friend who works in the health industry. And we just pick at each other's brains and share women's health information and obviously dismantle all the health misinformation that's out there, very importantly. And we try to tackle all these topics through a scientific lens. So that's really what I'm up to. And yeah, thank you again for having us. Emma she apologizes she can't be here. She's based in France, a bit far away.
I hope that actually one day we can all have another group discussion together.
Absolutely.
I'd love to do that. But we're so lucky to have you anyway. I do have quite a few questions to ask you. I mean, there's so much to cover, really. It's sort of endless learning. And there's so much more to discover, I think, in this whole realm of sort of female health, especially with all the new information that's recently come out on perimenopause and all of that kind of information coming out that's new to a lot of us. So it's very exciting. But I wanted to start off with something that I've personally recently experienced, and I know that it's extremely common, and it's to do with stress and how they affect your periods. Obviously, there's a huge impact. So yeah, I'd love to sort of delve into that.
Yeah, absolutely. So much to unpack there. In fact, fertility couples, when they're embarking on their journey, it's a topic that's heavily covered in the first initial consult, I mean, amongst many other things. Medical conditions, medications, there's a whole range of factors that can impact reproductive health, but stress, most certainly one of them. And the way it does that is through the HPO axis. So it's a long term. I'll say it's the hypothalamus pituitary ovarian axis. So the hypothalamus and the pituitary, I'll try not to make it too scientific, but basically it resides in the brain. And then you've got the ovaries down here. And essentially cortisol, the release of cortisol, impacts the GnRH hormone, which sits in the brain. And then when that's inhibited, it can no longer stimulate the release of our FSH and LH hormones, which are released from the pituitary, also in the brain. And then if that's not released, your estrogen and progesterone will be impacted down in the ovaries. And it's just this brutal cascade, because essentially if you don't have the estrogen and progesterone being released, it no longer can trigger the ovulation. So basically both systems work on each other is what I'm trying to say. And it's obviously through quite a complex system that's maybe a little bit high level to explain in this podcast, but huge impact. That's really all one can comment on that. So you have to have your stress under control. And I really hate to gaslight my female patients who are struggling with fertility issues or who're struggling with ovulation, just saying, oh, like, you sort out your stress. That's because it's not the only thing. Of course it's not. There are many factors, but stress is definitely one of them. So one of the best things that you can do if you're trying to fall pregnant, I tell all my friends, who are trying, just try not to overthink it. Like, don't overthink it. Obviously you have to be proactive, and yes, if you have any questions, come and chat to me or go chat to a doctor and, we can address it. But, overthinking and just stressing out is not doing you any good. Yeah.
So I have a question leading on from that. What would you tell a patient who's sort of heading for perimenopause? Her periods have stopped. She's under a lot of stress, but she doesn't know, is it this, is it that? And sort of how would one find out? Would she do a series of blood tests Would that be like the only
Yes.
way to do it?
No, it's obviously one would have to take, the doctor would have to take a comprehensive history with the patient, right? Are there prior psychiatric diagnoses? Is she known with anxiety and this is like her baseline and now it's just being precipitated? Or is this completely new? Like, now this is popping up in the perimenopause phase. So that's very important to classify because management would differ depending on what the doctor's findings are. So that aside, yes, blood tests can be of aid, but generally speaking, we do not do blood tests in women over 45 if we have not had a period. Okay, that's because it's a waste of resources, waste of money. It's like call a spade a spade. Like, what are we looking for here? I mean, the testosterone might be of benefit because it could aid further decisions down the line, whether we also want to boost with testosterone replacement therapy, but we don't have to go into that now. But if you're over 45, I would say leave the blood tests, clinical diagnosis. If you are under 45, maybe, especially if there's a confusing picture of irregular periods. I know you mentioned no periods, which is pretty diagnostic. However, if you're under 40, this needs to be investigated. Absolutely, no questions. You need to do full panel hormones. You need to even potentially go have an ultrasound, have a look and see, because it needs to be investigated because it's otherwise known as primary ovarian failure if you're under 40. So I would say, in answer to your question, it depends on the age, depends on the clinical context. Every patient's unique. Every patient's presentation is different. So there's no clear-cut answer. Individual tailor-made treatment per patient.
Yes.
Yeah.
Amazing. Thank you. Okay, that's a lot to certainly take in and think about, but amazing also to know that there's I think the greatest thing about this is to know what procedure to follow, like step 1, step 2, this is how I'm going to find out. So the next big question I have is obviously perimenopause on everyone's lips.
Yes.
That I know, certainly, all asking each other, do you think you have it? Do you think you have it? It's so fascinating, though, well, the first thing is that it's great that we're finding out that, this information is coming out. It can help a lot of people, make situations more understandable, getting to know your body better. But it's also sad that it's taken this long for this to come out into the public almost,
Right. And to think of all the women that have been gaslit until this point.
Of course.
Shocking. Yeah. So, no, there's just so much to talk about when it comes to perimenopause. It's definitely my area of interest. It's a topic that's close to my heart. I don't even know why. I just love it. I love all things women's health, but perimenopause is just such a complex time in a woman's life. And it's also new to us. I mean, the fact that I was not taught about this in medical school, the words never even crossed the lecturer's lips. I didn't find it in a textbook. I worked in a gynae ward for a year. Okay, granted, a lot of the patients I saw were obstetric patients or pregnant patients, but still we had a clinic, a gynae clinic, where we'd encounter older women with other reproductive issues, and it was not part of our screening. It was not part of our training. There was absolutely zero emphasis on it. I don't know. I almost think to myself, as a woman, is our role just to reproduce? Is that why all the energy and education is diverted there? Because yes, of course it's important. We should never neglect that. Okay. I'm very grateful for all the advancements in health pertaining to obstetric related health and wellness. But perimenopause, menopause, it's important too, because at the end of the day, as women, I mean, we're all now surviving way beyond our years, which is great. But the quality of our lives are significantly diminished. And what's a life worth living if you're enduring all these symptoms and nobody cares about you and your health and you're just gaslit all the time? It's an awkward phase. And I'm really, really glad that finally people are speaking up. We're educating ourselves. We're upskilling in this area. We're learning to identify and treat and just enhance women's life, because women deserve more than just giving childbirth and reproductive health. We actually deserve a good quality life at the end of the day. So yeah, lots to talk about. I'll let you lead the questions because I could speak for hours.
So it's almost, I think, I'm obviously facing perimenopause quite soon, and although there's a side of it that is quite sad, you're leaving a chapter behind, and it's quite a big chapter of you, if you've gone down that route, of course, but there's also, it's a time of a new beginning, essentially. It's a new chapter. And I think if you get the right support and the right knowledge and all of that, you can really, it doesn't have to be, these typical, this menopausal, crazy, hot flash, they can be managed. They can be not as bad as it could potentially be.
Yeah, Kat, I'm really glad that you mentioned it, because I'm making it sound like all doom and gloom and terrible quality life. And no, everyone experiences it differently, firstly. Everyone's experience of perimenopause and menopause is different. And the quality of our symptoms and the durations, it's all different. It's all unique to every patient. However, yes, with the advancements in medical technology, we do have access to HRT and the most incredible medications that are now at our disposal. So women do not have to suffer in silence. And I love the way that you mentioned that we really should reframe our thinking and almost look forward to this time in our lives. View it as a new beginning, freedom from menstruation. I can't even tell you how many patients I see that bleed to death every month, that suffer from the worst terrible cramps, that face the fear of unwanted pregnancies. And, finally to shift away from that tumultuous time and actually just embrace the new chapter where you're free of all of that. Yes, you might be burdened with a symptom or two, but at the these things can be addressed and they can be managed, and you don't have to suffer in silence. So it actually is a time that we should start embracing. And I'm in my 30s, and it's not that I'm looking forward to it or not looking forward to it. I'm really ambivalent, but I am taking proactive measures now because I know kind of what may be in store for me. So let me shift my focus on just leading such and such kind of a lifestyle to better my chances of just going into my 40s and beyond with a healthy and excited mind.
Amazing. I wanted to ask you another question related to perimenopause. What is your opinion on exercise, but very regular exercise and hormonal health? What is the impact of that sort of regulation, maintaining levels of hormone and all of that kind of?
So my opinion is that exercise is very beneficial, and consistent exercise is beneficial, but some exercise is superior over others. And specifically in your 30s, before perimenopause, one should focus on weight resistance training, kind of get those stores, get that resilience, and that should actually proceed into your 40s as well, so much as one can tolerate. But there's no reason to not be able to tolerate that if you're building up that resilience in your 30s. So I'm a huge advocate for weight resistance training because healthy muscle equals healthy brain. And as we know, brain talks to ovary. And so, yeah. But if that's not your thing, you don't like lifting weights, fine, but do something. Anything, just do something. As long as you're consistent. I'm also a yoga girl, and I know Emma can speak for her. She's a Pilates girl. Find what works for you and do it, and do what makes you happy. Do it consistently, switch it up a bit, do a bit of everything is also good. But if you can, you encompass weights into your training, that would be the best, in my opinion, and as according to my research.
Yes, and in the same token, nutrition and hormonal health.
Yeah. So we're so behind on the research. It's embarrassing. So when it comes to nutritional research, I'm always very hesitant to give specific dietary recommendations because I'm yet to stumble across guidelines. But the basic principles hold true. So stay away from a pro-inflammatory diet. It's obvious. Eat an anti-inflammatory diet. But what does that actually mean? So I think to kind of think of it, I opt for the way I try to explain it to my patients is that the Mediterranean diet, very healthy, fresh produce, minimally processed, high in veg and complex good starches and antioxidants, so the berries and the nuts and the grains. I mean, all of that is food for the brain. A little bit of fish. I personally don't really like meat, so I hate to advocate for meat, but there's nothing wrong with meat. In fact, I would even argue it's good in moderation. So I think everything in moderation is always the safe thing to say, but keep it healthy. Don't do the takeouts. Don't buy things that come in packets and plastics and I know convenience always wins at the end of the day. And I mean, I lead a very busy lifestyle. So sometimes it's just easy to buy a ready-made Woolies thing, whatever, just heat it up. But I mean, is that good? Probably not. But diet plays a huge role. And I think, just do a diet that's healthy, antioxidants, all the things I said. For Mediterranean diet is generally the diet that's advocated for when it comes to brain health. Yeah.
No, everyone speaks about getting your education on TikTok and Instagram and that, but I often see these Instagram sort of depictions of fruit, and they say blueberries for antioxidants, and I think it's citrus for estrogen. Is there any truth to,
So blueberries are
blueberries
very
are
high in antioxidants for sure. Oh, no. Like blueberries are brain food. Love blueberries. If you can eat all the berries
Yes.
of the world, like eat blueberries, all the berries, they're great for you. Strawberries, high source of vitamin C. All the berries are good, but citrus and estrogen, I do not know the link. They might be. But what I can tell you is that it's all the soybeans, the isoflavonoids, the phytoestrogens, like the all beans and like edamame and all of that. That is actually, that's fantastic. The legumes there, that's the word I was looking for. Exactly. Those are phytoestrogens, and that's high in estrogen and very beneficial. Is it superior to HRT? So in other words, can you like out-eat your symptoms? Probably not, but very beneficial. If it works for you. Some people have intolerances and they can't eat them. For them, eating legumes will trigger inflammation in their guts, like IBS symptoms. Who knows? So for them, no. But for you and me, we don't have those ailments. Great. So I'm very cautious to give personalized dietary recommendations because it is so
different.
It's so personalized. Yeah. Do what eats for you that's not inflammatory for you. And blueberries are good and phytoestrogens are good. Yes, if you can tolerate them.
Perfect. So then you mentioned something about the lack of data. And that has been one of the things that I have noticed and come across, and it's so frustrating. If it's not ancient, it's not South African. So you've got British, you've got American data from the 70s or something. Nothing is up to date. And I just wanted to talk, is it that bad? Are we that behind? And also, why are we in this situation?
Yeah. So we're slowly catching up, in answer to your question. I don't know if you're referring to we as in South Africa or we as like the global
South African women
South
in
Africa.
particular.
No, South Africa is behind. We are behind. It's sad. A lot of my resources are drawn from overseas sources and overseas guidelines because the guidelines here don't exist as far as I'm aware. Why are we behind? Well, I think firstly, women were largely excluded from clinical trials until the 90s globally. Okay. And this is due to a combination of scientific, ethical, and social political reasons, many of which were rooted in paternalistic and gender-based assumptions. So if I could just quickly expand on that, women were perceived as small men, and their physiology was just deemed as too hormonally complex to be studied because you had all these confounding factors. It would make the study, it would complicate the study. So like, why bother study women? It's just going to be too complicated. They're like small men anyway. And this went on for years until the 90s. That is wild. Can you imagine? And then obviously there is like gender-based bias in medicine. So like, why do we care about women anyway? It's actually, it's very complex. Aid to all the complexities, there was the thalidomide tragedy that happened in I think it was the late 50s, early 60s, Germany, somewhere in Europe. But essentially what happened was women were given anti-nausea medicine in pregnancy. So they were all pregnant, the women that received this drug. It was studied on rats, the drug. I don't think it passed human clinical trials. And a large cohort of these women then gave birth to babies with limb defects. Okay, this was early on, like late 50s. Obviously, this triggered a lot of fear as well. So a lot of people were like, shit, like stay away from pregnant women, like do not mess with them, do not give them any drugs. And I actually understand to some extent. So everyone's so nervous to test on women, especially pregnant women. So just rather stay away from any women of reproductive age, just don't study them at all. But of course, in the 90s, people realized we can't just completely ignore 50% of the human population. We have to find ways to mitigate these issues. And then thankfully, I think the US led the way with changing the laws and ensuring that women actually got studied. And then this passed over to Europe. Here, yes, we are studying women. Women are involved in clinical trials, but I don't know why we're still behind when it comes to guidelines, especially for doctors and educating doctors on all these symptoms of, like, for example, perimenopause, menopause, the topics that we're speaking to today. It might have changed now. I've been out of medical school for 4 years. I hope it has. It's just, I think it's just it's just happening slower in South Africa. Maybe we have, because we've got other priorities. I don't know. I don't really have the answer to that question. But I'm doing my best to change that and to just empower South African women to know their reproductive rights, to know their health rights, to know when to speak up, how to empower themselves, to recognize symptoms. And slowly the paradigm is shifting. It's just taking a bit more time.
Wow. It's incredible. I read something the other day about testing on menstrual products, that they were never really tested on women. And I thought, this can't be real. How's that even possible? So you don't know the effectiveness of this product. I mean, how are you going to market with this?
That
It's
makes
crazy.
sense. Yeah.
And
Yeah, that
then,
is crazy.
they say that tampons are actually not great for you anyway because they cause, toxic shock
Toxic
syndrome
shock
or something.
syndrome. Very rare complication, but it can do that if left inside you for many days. I haven't actually seen a case of that, but yes, in theory, it can cause that, sure.
Yeah.
There are other concerns about the chemicals and the tampons.
The chemicals, yes.
Yeah. I personally am a menstrual cup girl. That's just my personal preference. It's better for the environment. It's great for my vagina. I just love it.
There's a lot of benefits.
Yeah, but some patients prefer tampons. That's fine. Like every patient must do what works for them. Like no one must be. If it works for them, there's been no complications, then do it. Don't let like social media fear you into anything. If it's working for you, it's working for you.
Perfect. Great. And then I want to go back to the perimenopause thing, but in terms of the dismissive culture, because now you've mentioned, the data on women and all of that. There's a whole context behind the scenes, whether it's political bias or whatever the case is. It's now this dismissive culture seems to shroud us all the time, in lots of different aspects. And I think with all the symptoms that you have leading up to menopause, some of it's really confusing and sort of at loggerheads with each other, and it can be this, it can be that. You don't really know what to think, and you're feeling terrible as it is. And it's just, judging from what I've heard from our friends, they've gone to their male doctors and that, and some of them have been extremely dismissive about these symptoms, or like, don't worry about it, doesn't matter, this is happening and just get on with it. Why do you think that is? Is it maybe only done here, or is this like a global thing?
I think it's a pervasive issue. So I think it's a global thing, in answer to your question. And I think it stems from the gender bias in medicine, the historical underrepresentation of women, the systemic inequalities that we spoke to before. It's rooted in so many of these issues. Does it make it acceptable? No. And that really breaks my heart that, to hear that it's still happening today from your own personal experience and from the experience of your friends. I was hoping that, we're soon doing away with this dismissive culture, because at the end of the day, it just breeds mistrust in the healthcare system. And then women feel disempowered, and then they don't want to come forward with their symptoms because they're okay and they're going to get dismissed anyway. And then everyone suffers at the end of the day. We need to do better as medical providers. We need to listen to our patients and explain our thinking and never dismiss. Any complaint is valid. It must always be interrogated. At the very least, take a history, do an examination, do some blood tests, do some ultrasound, I don't know, do something before you just dismiss it, firstly. And then, in the presence of all perfect results, no complications, you counsel the patient. You say, okay, fine, it might be not show up on the blood work, but not everything does show up in blood work, and your symptoms are valid. And this is what I could refer you to this person or that person to interrogate your psych symptoms. Say you've got underlying anxiety at the end of the day. You can't pick up anxiety on blood work. Do you know what I mean? Does that mean that it must be dismissed? Absolutely not. It's just one example. So doctors need to do better, and women also need to be more empowered to know, okay, that doctor dismissed me. I'm not happy. Let me seek another second opinion. Yeah.
Perfect. It's you're so
where
right.
I can feel validated and reassured and safe. Because at the end of the day, when you consult a doctor, a lot of my patients, they're so shy, they're so vulnerable. I don't know, but then I actually reflect on when I go to my gynae, I'm the patient. I feel vulnerable. It's your personal life that you share. It's your symptoms, a physical exam that you subject yourself to. So it's multifaceted. Definitely, yeah, it's important to feel safe with your provider. So if you're not feeling safe, that's a red flag.
Especially when you don't have answers and you're feeling scared. Maybe it's something you're experiencing that you haven't experienced before. It can be really, really overwhelming.
Yeah.
You know when you get a cold, you know what the symptoms are, you know what you're going to be prescribed, the medication or flu, but the hormonal things can be very different to kind of deal with. There's a whole
Sure.
psychology behind it. It's much more complex than just, I have a cold.
Yeah.
There's layers.
Absolutely. Really. So no, that's very true.
Okay, perfect. I wanted to also chat about another huge topic, which is, there's so much to talk about this fertility and where it goes wrong. And I think, I personally have had sort of diagnosis given to me when I was much younger that turned out to be completely incorrect. And it wasn't just given to me by one person. It was given to me throughout my 20s and early 30s. And it had a huge impact on me. But there's also like some mystery about fertility, because I think sometimes all the things can lead to a certain picture and a certain assumed outcome. For instance, like when we're talking about falling pregnant and say the person's really struggled to fall pregnant and then they go on an IVF journey and then they suddenly, they don't experience that with their second child. And I have heard that's a lot to do with stress as well, because the stress is kind of taken out of and we were talking about how important stress is with regards to that. So there's just so much around fertility that is kind of not really, maybe not understood or not, I think just basically not understood.
Yeah. At the end of the day, when it comes to fertility, there's so much to unpack. And I suggest to all your listeners that you tune into our fertility episode. We also do a really good episode on egg freezing. I believe it's a good episode. Just, explaining all the process behind it, which is some of the steps that's involved before IVF, which is in the fertility episode, we cover that. So there's just so much to talk about. I ramble on about it for, I think, like 35 minutes. But in summary, it's, just for your listeners here, multifaceted, very complex, but also very important for me to reiterate that 30% of the time, the onus is actually on the male. And I think we don't talk about that enough.
Really?
So yes, 30%, that's like a huge proportion. So if you go to any fertility clinic, it's that the male has to get the sperm tested before any further conversations. Like you have to produce a clean sperm test. There's no pathology there before one wastes money on unnecessary resources investigating the female factor. So many areas that it can go wrong. We don't have to really discuss that now, but I think when it comes to infertility, one of the biggest challenges is that women are delaying childbearing. I myself find myself in this situation going into my later 30s. So, we're focusing on our careers and relationships don't go according to plan. And we're delaying we're delaying. And it's not to say that if you're over 35, you can't fall pregnant. That's not what I'm saying at all. We see people in their early 40s falling pregnant. Of course, anything's possible. But you are pushing it a bit because by the time you're 30 years old, you have 10% of the egg supply that you were born with, which is not many people know about either. Born with like 2 million little miniature eggs, which then all disintegrate. And by the time you reach puberty, you're sitting at around 300,000 to 400,000. I know it's a large range, but that's what the studies suggest. And then I didn't count this myself, just by the way. And then with every menstrual cycle, you don't just lose one egg, you actually lose like 20 to 40 that get recruited with each ovarian cycle, and then one kind of pops up, but then the rest disintegrate. And by the time you're 30, you're left with 10%. 10% is not nothing. It's enough to be able to fall pregnant, of course, but it's a lot less than what we're gifted with at birth. So we are a lot less, also the quality of our eggs diminish with age as well. And then, of course, all the lifestyle factors which contribute. Lots of people smoke these days, lead anti-inflammatory lifestyles, we're stressed, which impacts everything. It doesn't only impact ovulation. There's so many impacts. It can impact implantation even if you have a successful conception. Well, the stress can impact any part of the pathway through inflammation. So yes, at the end of the day, erratic work hours, relentless cultural expectations as well, all further precipitates the stress burden, makes one feel even more stressed. So yeah, there's so much to talk to when it comes to stress. But the question of whether infertility is actually on the rise is actually a disputed subject, because some of the studies, I think the WHO released a statement, I think it was in 2022 though, saying that no, it's actually not. It's just that if you were to take a cohort of 35 pluses in the 2090s, they also would struggle. It's just by virtue of their age. But that was never studied, so we don't have the comparison. But now that we have advancements to assisted reproductive technologies, now that we have IVF, we almost are like overdiagnosing and catching fertility problems. I'm not arguing that they're not there, by no means. I don't know for a fact whether I can conclusively say that it is on the rise. I suspect it is, but just given all the lifestyle factors that we alluded to earlier, how can it not impact fertility? I'm sure it does. But yes, I think just not to underestimate the role of the male, the male, and also like his lifestyle. So if the male's a smoker, the use of tobacco can definitely impact male fertility factor as well as female. Alcohol as well, correct. And obesity. In both males and females. I mean, also being super, super underweight, BMI less than 18 in females is also a problem. So over-exercising is a problem as well. More than 5 times of like high-intensity, vigorous exercise, and you're like a BMI less than 18. That's also problematic.
Yes.
But the opposite end of the spectrum also holds true. So if you're obese,
yes.
it's also
so no
a problem.
extremist kind of.
Just, yeah, exactly.
Just
exactly.
middle of the road.
Middle of the road, yeah.
What are your I'm putting you on this?
I think it's fine if you can fall pregnant.
Then
I mean, that's great. I know many people that successfully manage to conceive.
Yes.
I know when it comes to IVF, most centers will use age above 40. Well, I mean, I think even above like 38. So it depends on the fertility center, but they'll use that as an exclusionary criteria just because the chances of successful IVF is so low of retrieving the eggs, and it's going to be way too costly because you have to undergo more rounds of IVF. So I know from that, in that regard, it's not advocated for. It's definitely it's not recommended by fertility clinics just because it's like a very hectic process for not so great results. But if you can fall pregnant and that's wonderful. I mean, yeah, absolutely. Of course, being older does also put you at risk of many complications in pregnancy. But I mean, if you're being followed up by a gynae and they're taking care of you and you've got a delivery plan, like, I don't see the issue.
Perfect. We've got just a few more questions. What would you, obviously an expert on ovarian health, what are maybe 5 things, or I mean, I'll leave that up to you, but what can you do to really stay on top of that kind of health? Just looking after your whole reproductive system.
I was going to say,
I imagine
yeah.
your sexual health ties into this immensely.
Yeah, well, I was going to make a joke and say reverse aging because that would definitely be my top solution. But no, so I would say it's the 5 basic pillars that we all reference in almost all our episodes, but they are so pivotal. Good diets, and what that means for me might be different for what that means to you. But I mean, I think for all intents and purposes, we spoke to an anti-inflammatory diet, limiting alcohol. Alcohol's not great for the ovaries. Also, it leads to chronic inflammation. And so diet, alcohol, maintaining a healthy weight is really important. Not being too underweight, but also not being too overweight, just being at a healthy weight, good BMI, that really supports conducive hormonal health as well. Your hormones are happy where everyone's in equilibrium.
Yes.
Sleep, getting good sleep. And that ties in with the stress. And I think we mentioned smoking already. Like that's a big no-no. It's obvious. But yeah, sleep. And then I almost want to say like relationships, but not necessarily with others. I think also relationship with self and just being in a good space. And yes, if you have a supportive partner, that definitely helps. If you don't, just falling in love with yourself and doing things that serve you, feeding the heart, and just taking time to just be in tune with your body and recognize your body's cues, what your body needs. Of course, sexual health, very important as well.
Self-care.
Self-care, absolutely. I mean, life is just too stressful these days. We all live like absolute robots. And sometimes I catch myself off guard and I just have to like take a step back and be like, no, like I'm a human being. And today I want to be in the mountain with friends and just be in nature because that's what serves me. And obviously, we can't do, it's not realistic to do this every day. We have to unfortunately work and earn incomes and podcast. I love podcasting. It's not a problem for me at all. As you can hear, I can speak for hours. But yeah, those would be the best tips for good ovarian health.
Perfect. And then the last question, what do you suggest in terms of frequency of tests? So I know tests are extremely important, your pap smears, and I think there are quite a few other ones to
mammogram,
get to the
bone
special
density.
tests, your mammograms.
Yeah.
So what kind of frequency are you looking at? Sort of your 20s, obviously not as frequent, or maybe does it get more frequent as you get older?
Yes, it would, yeah. So, I mean, let's just say from 40 up. So, yeah, at 40, it would be advisable to go for a mammogram, I would say. As a check-in, nothing unreasonable about that. In terms of the follow-up with regard to the mammogram, it depends on the findings of the mammogram and your specific family history and risk factors. So the follow-ups would differ, but as like a baseline entry into 40, that's great. If you haven't had a pap smear, I would advise you do so, especially at 40. You should have had them in your 20s and 30s. It could be up to even 10 years if there's nothing wrong. The guidelines constantly change, and also depends on whether you're HIV positive or negative. Okay, but assuming you haven't had one in a while, you go for your pap smear. Bone density scans come in a little bit later. I'm not actually entirely sure of the age. I think 60, but definitely by 60, but it could be sooner, especially if you have risk factors. So definitely best to touch base with the physician or even a GP. You can then just sit down and look at everything and formulate a plan. Yes, and then the rest would, I mean, there's also the colonoscopies. That's not pertaining to women's health specifically. That's colon cancer, which women and men can succumb to. So I think a routine colonoscopy, not a bad idea. Also, I'm not entirely sure of the age. Check in with the healthcare professional and then they can again make that assessment. But yeah, the guidelines differ depending on country to country. But in South Africa, I'd say those are the top ones. Ovarian cancer is aggressive and something that absolutely needs to be screened for, but we don't have a blood test yet. And it's one of the most aggressive cancers that we have. And unfortunately, by the time we catch it, it's stage 2, 3, 4.
Is this what's called the silent killer?
It is absolutely, like, ovarian cancer is one of the most aggressive cancers we have. And there's no routine blood test that we do for it. So there's no diagnostic blood test. They can say, oh, you've got ovarian cancer. There's some markers that we can look out for, but doctors don't request those blood tests routinely unless you're symptomatic or you're losing weight or there's like a reason to do that blood test. I'm hoping something will change and we can catch it quicker.
Do you know what the data in South Africa is for that? Do we have any stats to do with, in particular, ovarian and breast cancer?
I don't know offhand.
I'm sure I'd love to know actually what that's. I know the UK is quite high with breast cancer.
Cervical cancer, I don't know why the number 4 is coming to mind. Like if it's the 4th leading cancer in South Africa. No, it's not 1 in 4, but I think it's like high up there. And I think South Africa has it particularly high because of our HIV burden. And that is a huge risk factor for the development of cervical cancer. That was actually going to
link into my next question because I wanted to ask you, how often do you think, it's obviously extremely necessary, it's not even a question of doing it, but what should the frequency be for STIs and HIV testing?
So HIV, it depends on your risk factors, on your exposures, on your sexual life. I mean, I'm a healthcare professional. I cut a lot of cesareans. My hands were deep in abdomens. I had blood trickling through the glass. So we all have different risk factors. So I like to test personally every 6 months, just given my lifestyle and my risk factors. But it's definitely, the answer is specific for every patient and the lifestyle that he or she leads. There's no guideline to say, you must STI screen at this stage. I mean, every time I go to the gynae, which is like every year, I do my screenings, but that's me personally. I'm requesting for it.
Yes.
It's not a guideline. If you're symptomatic, consult a healthcare professional, and then we can diagnose it, treatment. Yeah.
Okay,
I'm rambling.
perfect. Thank you so much. This has been so interesting.
Yeah.
I want to now go and look up these stats. I'm so interested to know now what we're sitting on.
Yes.
I wanted to ask you, if someone has a question based on what we've learned today, how do we get hold of you? I know obviously you are on Instagram with the Ovarian Club, so that's one place.
Yes, you can find us at the Ovarian Club on Instagram. We're also on all streaming platforms. So if you want to tune in, you can listen on Spotify, Apple, and YouTube at the Ovarian Club. But you can also contact us via our email, theovarianclub@gmail.com. And yeah, but we're also on TikTok. We're not great at it, but we're trying to figure that out. But yes, Instagram, you can pop us a DM there if that's where you feel comfortable messaging. You can drop a comment on any of our posts. We're very active. We're on the socials. We're here to address any questions that you have, any topics you want us to cover. And yeah, we're available. We're here. We want to empower women, and we have a very exciting episode coming out, yet to be recorded, but on sleep and just like evidence-backed ways to improve our sleep. And yeah, we're going to be exploring all of that soon. So that's going to be coming out shortly.
That is going
way
to
more
be
exciting
huge.
topics. Yeah, the supplements,
sleep,
which ones to take.
Older, the quality really, really decreases.
Yes. Yeah. No, I'm doing the research, led me down rabbit holes, and I'm really excited to share all the information that all my findings.
So exciting.
Yeah.
Amazing. Thank you so much for joining us today. It has been the best conversation. So much interesting information.
Anytime, Kat.
Thank you so much.
Thank you. Great.
Thanks.
Bye.